My name's Professor Terry O'Brien. I'm head of the Central Clinical School and at Monash University, and this is our annual CCS public lecture, which is our showpiece offering to the community to show some of the really fabulous research work that happens across our school, and it's really is a great privilege to be here in Peninsula Health, to be able to highlight some of the wonderful work that happens at Peninsula Health. A lot of people think we're very Alfred-centric, which we sometimes seem to be, but we're really not. We appreciate that there is tremendous work done in the school and university at many of our other campuses, and Peninsula is certainly one of them. I'd like to start by acknowledging the traditional owners of the lands on which we meet today, and we're meeting on the lands of the Burrarong and the Boonwurrung people of the Eastern Kulin Nation, and pay our respects to their elders past, present and emerging. Today is actually the kick-off for Peninsula Health Research Week, which is a wonderful way for Monash to have the privilege of kicking off Research Week. After our public lecture from Professor Srikanth, we're going to have the opening symposium with two presentations, followed by and we'll have some Q&A after the public lecture, and then the two presentations to follow. So I'd like to with no further ado, introduce our star of the day, our public lecturer, and that's Professor Velandai Srikanth, who's Professor of Medicine in the Central Clinical School and Director of Research at Peninsula Health. He's Director of the National Centre for Healthy Ageing, which is a Commonwealth-funded partnership between Monash University and Peninsula Health, which is designed to fund research that helps us all age better, particularly with regard to brain health, which is the topic of the day. Professor Srikanth's program of research is absolutely outstanding and spans several aspects of healthy ageing and disease. His primary interest is studying the risk factors and mechanisms underlying dementia, particularly with respect to vascular and metabolic health. He has led the field internationally in studying the impact of brain ageing on walking and the risks of falls, and the link between brain ageing, gait and the risk of dementia. He is now working to understand the impact of health at later stages of life on future dementia, risk of dementia, and how this risk may be minimised. So he's going to talk to us today about the ageing brain and what we can do about it, which is something that I have great interest in, but I'm only asking for a friend, Srikanth. Over to you.
Thank you, Terry. I would also like to acknowledge the local traditional owners of the land we're on, the Boonwurrung and the Boonwurrung people, the people of the Kulin Nation. So thank you, Terry, for that kind introduction. It's an honour for me to be able to present at this public lecture for the Central Clinical School. And the Central Clinical School is the school in Monash University that we researchers in Peninsula Health are largely affiliated to and are part of. So what I'm going to speak to you today over the next 30 or 35 minutes is about brain ageing. It is a favourite topic of mine. It's the topic that I have grown up researching from my PhD years. What I'll be actually addressing is, why does the brain age? What causes dementia? How do you link brain ageing to the concept of dementia? And then what can we do about it? So why talk about brain ageing? Because it helps us understand how to maintain our brain health, to help prevent or delay the development of significant brain-related conditions as we get older. And dementia is not the only condition that our brain gets affected by as we get older. There are other conditions such as stroke, other conditions such as Parkinson's disease, much of which a lot of you might be familiar with. And these conditions are somehow connected in the way they develop. So understanding what leads to that as we age is important. When we know when we understand what happens, then we're in a better place to know what to do to prevent brain aging. So the figure that you see shows a brain on the left, to my left here, which is that one there. That is what you might expect if you did an autopsy on a healthy person who doesn't have dementia at death and usually displays a nice, well-preserved brain structure. This other brain that we have there is what we would expect in someone who dies from dementia. You can see that the brain is shrunken, much more compared with the healthy brain. So the talk that I'm going to give you today is centered around how this happens. But first, I'm going to give you some key facts about dementia so you can have it in context. Then I will speak to you about how brain aging, as I understand it, may become dementia. That leads into identifying who might be at risk early on in their lives and how might we prevent them from getting dementia. And finally, there are some people who will go on to develop dementia and symptoms of dementia. How do we help them once they have the symptoms? So some facts about dementia. Dementia touches many of us. It's touched people in my family and us. So that is my maternal grandmother, who at the age of about 70 developed a few strokes, and then a few years after that developed symptoms of dementia. She is no more. That is her when she was about close to 70 years of age, and that is when she was in her late 80s with her grandchildren, or great-grandchildren actually. You can see the difference in the way she looks, but more importantly, you wouldn't have known looking at her that at the time she was unable to recognize the grandchildren. This is us, my wife and I, getting married in 1996, and that is my mother-in-law, who was really fit and active and a really strong person, and she has gone on to develop dementia, and that is my wife with her just a few months ago. She's still with us and with a good quality of life. So to understand what is dementia, you need to understand some simple concepts first. The way I see dementia is quite simply a progressive decline in more than one type of cognitive function. Commonly, we talk about memory as being the cognitive function that we think about. There are other types of cognitive functions which are affected. And so usually when a person is diagnosed to have dementia, they have more than one affected. With time, as it develops, it begins to affect a person's life. And it's usually detected only when a person begins to express symptoms, either to us as family or to a physician or a health professional. This graph here, and I'm going to go back to this every so often to tell you what this is about. If you look at that red line there, that is what we call our threshold as health professionals for being able to detect dementia. And that's advised and governed by the kinds of tools that we have, which are constantly evolving. So about 30 years ago, we might have been very poor at diagnosing dementia and detecting it. Now we're much better. In about 10 or 20 years, we might be a lot better. But that threshold determines when we find someone expressing a symptom. You could have potentially three different scenarios. A person whose brain is aging, and if you assume that as people age, they lose some cognitive function, but that person may never reach that diagnostic threshold for dementia or symptom expression in their lifetime. There might be others who reach that threshold, but at different times. So if you keep this difference in trajectory in mind as I go through my talk, it would help you understand what I mean by prevention of dementia. The scale of the problem, it is a huge problem. The Australian Institute for Health and Welfare released a report, which you all can see in the web in 2022. They estimate the number of Australians living with dementia in about 2021 to be about 386,000. Somewhere between 300 and 500,000 people in Australia live with dementia. Those estimates need to be much more accurate. I think we're just touching the tip of the iceberg. There are many people out there who we don't know have dementia, but probably have symptoms of some kind. How do we compare with other countries? We're somewhere in the middle. These are the OECD countries, and Australia is somewhere in the middle of the curve. What about our region here in Melbourne? And these are numbers again from the AIHW report. These are by areas in Melbourne here. You look at eastern Melbourne, southeastern Melbourne, northwestern Melbourne. Much of Melbourne has really high numbers of people living with dementia. The southeast has about 20,000 people on average, if you consider that these figures are reasonably accurate, but I suspect it's more. We're trying to improve how we record and diagnose dementia and monitor it in a project that we're currently running. And Associate Professor Nadine Andrew from our school is involved in doing this by looking at various kinds of records which might help us, such as electronic health records. Now, the impact of dementia is huge for people. It is the second leading cause of death in Australia, but amongst women, it is the first. It is the third leading cause of disease burden. When I say disease burden, it's a number of years that it takes off your life because of the impact of the disease itself. But again, for women, it ranks first. So women are dealt a raw hand here. In 2021, it's also estimated there are about 150,000 unpaid carers who look after people with dementia. And that is something which is not counted usually when we see people. Half of these primary carers for people with dementia are their spouses. 47% of primary carers were providing on average 60 or more hours of caring for their partner or loved one in that time. So that's about the scale of the problem and what it is. What about the causes of dementia? What causes it? And that's something which is often not talked about in a lay or a public setting. These are some Australian scientists who have led the field in understanding certain pathologies that happen in the brain while dementia occurs. Professor Masters, Ashley Bush, Jürgen Gotz, Rosie Watson, Ralph Martins, Chris Rowe. These are all people who are really well known for their work in identifying and tracking the kind of brain changes that we see often in people with what we call Alzheimer's type of dementia. And the kind of proteins that are developing in these people's brains are termed as amyloid proteins or tau proteins, Lewy bodies, and a newer kind of protein which is called TDP43. These are technical terms. But all these proteins, the way they act in the brain is to cause either dysfunction of the brain cells or loss of brain cells prematurely. And then there is another bunch of people who have led the field, including myself, harping my own research here to a certain extent, looking at the impact of other kinds of disease on the brain, such as vascular disease. So when I say vascular disease, it's disease that arises because of blood vessel health or heart health. And so obviously there are a number of things which manifest as this, and I'll take you through these in a little while. But these are the people who have led the field. Amy Brotman is also in our school. She's led the field in understanding how stroke leads to brain cell loss and dementia. Chris Moran is in our school and has studied the impact of diabetes on brain health. And there are others nationally who've also led the field. There are two camps of people that have developed over time. One camp looking at predominantly the proteins that I described before, another camp of people looking at these kinds of conditions. And it might seem to you that there are two distinct camps, but not so. Before I go on to that issue of the camps and how they come together, you'll see here pictures of brain scans. And what it tells you, there are a number of kinds of conditions affecting blood vessels or the heart that can lead to a number of different kinds of changes, some of which occur abruptly, like strokes, which are infarcts or bleeds in the brain, but some of which accrue silently in the brain that you don't know about. And when you do a scan, you'll find them, such as these changes, these white matter changes, these little bleeds that we might find occasionally. And if we do much more highly developed scans, you might find tiny little infarcts in the brain or loss of brain cells through blood vessel disease. But really, both the camps have in the last 10 years understood the phenomenon a bit more and have agreed that it's a mixture of causes that leads to a person expressing symptoms of dementia. So it's now accepted without a doubt that the majority of people who have dementia have more than one type of pathology in their brains. And if you look at these graphs here, they tell a story. These are graphs derived from a particular study, but there are several such studies like this that show the kinds of changes in the brain at autopsy in a person who's died from dementia and people who've died without a diagnosis of dementia. You can see that the most common finding amongst those who died with dementia is a mixture of all these conditions. In those who died without dementia, the most common finding is probably not a lot of change, but interestingly, you find that even they have some changes occurring in their lives, but they haven't reached the point of developing symptoms of dementia. You find that the mixture of reasons which describe a person's predilection for dementia are not as high in those who die without dementia. So essentially what the story tells us is that a person who develops dementia has a mixture of causes which either directly cause neuronal or nerve cell loss in the brain or act via blood vessel health, leading to loss of neurons. And the two are mixed. The same study also showed this important fact, and this shows that the greater the burden of such mixture of diseases in the brain, the sooner the expression of symptoms of dementia. So these are the number of pathologies in the brain that were described. And as you go from no pathology in the brain to more than 3 pathologies in the brain, you find that the score in a cognitive test reduces quite dramatically. So this leads to concluding that to express symptoms or signs of dementia, you need to have a lot more pathologies and a mixture of causes in your brains. So the summary of that particular little bit that I've talked about, facts about dementia, it is a highly prevalent and leading burden of disease. At death, most people with dementia have a mixture of pathologies in their brains, suggesting the presence of multiple causes as the most common scenario. The more the number of pathologies, the greater the impact on brain and cognitive function, and hence the earlier expression of symptoms of dementia. And if you look at this figure, which I showed you before, what I've now done is put in this person as potentially having a low burden of disease, this person having the greatest burden of brain disease, and hence this person might reach that diagnostic threshold for dementia much earlier. So now I'm going to flick back to the concept of brain aging. And brain aging is something that we worry about. Terry spoke about, I don't want to know about what's happening to me, but we need to know a little bit about what's happening to us and how it might either turn into dementia or not. The first question everyone has is brain aging synonymous with dementia? And underneath that is the question, will everyone get dementia as they get older? The resounding answer is no. In fact, the prevalence of dementia in people over the age of 80 is somewhere between 20 and 40%, depending on where you measure it. But that means there is another 80 or 60% of people who don't have it. And that's a common fact that is disregarded. But what is usual brain aging? Till now, we haven't had a real glimpse of this. When you go to a pediatrician with your child, they would look at growth charts for their development. These kind of charts have not been available for the brain till recently. And this particular study, which was published in the journal Nature this year, was a huge effort on the part of hundreds of people. One of our scientists, Richard Beer, was involved in this whole process, where researchers pulled together about 120,000 brain scans from all over the world and developed what they consider is the most comprehensive growth chart for brain. And if you look at this chart, it talks about what the brain size or volume might be even before birth, using fetal ultrasounds, right through to late adulthood, 100 years of age maybe. What I want to point out here is this. The simple message is these growth charts suggest that the brain expands really rapidly in very young age, in childhood, and then slowly shows shrinkage as we get older. This is mostly in the absence of disease and events. So we can assume that this is a growth chart that tells us what brain aging might look like as we get older. If you look at this orange curve, it talks about the grey matter volume, which is the bit that is involved on the outside of our brains and maybe somewhere deeper that contain the nerve cells. That peaks at the age of 6, late childhood, and then slowly starts to decline over a long, long period of time in a very small bit. And similarly, the other parts of the brain that we can see on the scan here, this one that goes up refers to the black bits here, which contains fluids in ventricles. As the brain shrinks, the ventricles get larger with fluid. Why does the brain age? There are a number of molecular processes involving our cells, our brain cells, that underlie it, and they're all mixed in together. It might be because we're not good at cleaning up bad things called free radicals in our brains. It might be because certain key things in our cells, the mitochondria which manage energy, are not working well, or the cell metabolism itself is not working well. It might mean that the nerve cells have some kind of impaired repair of their DNA, which allows them to refresh themselves, or in some people there might be a low-grade inflammation that persists that contributes to loss of cells. All these processes are common to both a direct impact on the neurons in the brain, but they also have an impact on blood vessel health, so the two are connected in a basic molecular sense. But what really interests us is what are the factors that affect these mechanisms, and what are the factors that affect the trajectory of usual brain aging as we understand it, and when do they affect it? The thinking now is that it's through the lifespan. It's not just when we get older. So whatever we do in our life before birth, through our childhood, midlife, and even in old age has an impact on our brain aging trajectories. Particularly in pregnancy for children before they're born, avoidance of smoking, alcohol, and other drugs is important, and maintaining a diet that is nutritious is important. We know that, and that probably has an impact on the brain. But the bulk of the data that we have in research that's been developed through our studies and studies from elsewhere show these factors which are protective, and these kinds of factors which increase the rate of brain aging. And what's common amongst all these age groups is that activity, which is physical activity, intellectual activity, stimulating activity, engaging with other people, is really important in maintaining the trajectory of brain aging. In early childhood, intellectual attainment is a marker for healthy brain aging. That might be connected to a whole number of other factors such as socioeconomic status, etc. Again, diet and weight are important even in childhood. As we get older, other conditions that we accrue, such as vascular risk factors because of smoking, etc., are important. What I'm going to do is give you some key examples of what we've done to establish these kinds of relationships. So this is a really nice study that was done by Michelle Calisea, one of our senior researchers in our school, and Jamie Tate, her postdoctoral fellow. And what they did was followed up a really great cohort of kids between the age of 5 and 17 from the Australian Survey for Health and Fitness that was conducted a long time ago. They followed them up till the age of 40, and they found that the fittest and leanest had the best cognitive scores, whereas the children who were overweight or not the fittest tended to have the lowest cognitive scores at age 40. And they were put through a number of interesting exercises, jumping, a 1.6 kilometre run, a 50-metre sprint, push-ups, etc. So this was a true examination of their fitness at young age. What this is telling us is how we are as children has an impact on our brains as we get older. Chris Moran from our school, with myself, have looked at the impact of conditions such as diabetes and how that impacts us. So this is an interesting twin study where we compared people with and without diabetes. One twin has diabetes, the other twin doesn't, at midlife. And what we found was that the person with type 2 diabetes at midlife had to work much harder to achieve the same cognitive task and use many more brain networks to achieve the same task as the twin without diabetes. Again, an indication that it doesn't matter if you've born from the same ilk and have the same age and other sort of factors to control for. Conditions like that can change how your brain works. Chris also showed that even in older age, in the absence of conditions such as strokes, etc., which can affect our brains, there was a difference in people with and without diabetes in their brain volumes. And that reduction in brain volume was linked with poorer cognitive function. So they're just examples of the kind of work that we've done, but it adds to a huge body of work that's been done internationally. What really comes out of this kind of work is an understanding that there are factors that protect against brain aging, more rapid brain aging. There are factors that promote more rapid brain aging. Those kind of factors that we talked about here in terms of activity, education, and childhood, they create what we call reserve or resistance or plasticity. These are concepts that are being explored more and more now, whereas the kind of harmful stuff that happens to us later on leads to the kind of abnormal proteins that develop in the brain that I showed you before, the silent vascular changes, and ultimately strokes and other conditions which can lead to this mixture of conditions in the brain which could lead to a dementia. So if you go back to that figure that I showed you before, the path from usual brain aging to dementia is not a certainty, but is what I call a net sum game. It is an expression. The expression or detection of dementia depends on the net sum of all these small effects from these multiple factors that we either have as protective factors or harmful factors through our lives. And it's hard to pin down one of these factors as the dominant reason why we have or develop dementia. There are several unknown factors that are still being explored, but we know that there are several known factors that promote brain development in childhood, provide a buffer against harm, and hasten brain aging as well. So if you look at that figure, now, apart from having the burden of brain disease that I spoke about before, somebody might start at a higher level of reserve and resilience, and hence might take that path, and somebody might start at a lower reserve or resistance and resilience and might take another path. So that's brain aging as I understand it and as the current state of play in research. But can we then use those concepts to detect people at high risk? And if so, what can we do about preventing the onset of dementia in such people? And prevention is about shifting the curve. It's about shifting the curve from here to maybe here. There have been some really good attempts to identify people at risk in midlife that might be at a higher risk of dementia in later life. A simple example of that is the score that was developed in Europe, which is now in an app. There are multiple such scores like this. They use several clinical characteristics in middle age to try and come up with an average risk of developing dementia 20 years down the track. Important thing here is to consider that these scores are not good for a patient or a person sitting in front of me asking, what is my risk, what is my certainty of developing dementia? And that's not what these scores are used for. They're used to group people at relatively high risk so we can test interventions in them that might be useful. And there has been a really, really good landmark study, 2021 it was published. It's called the FINGER study. It's the Finnish study, which is why the F, and it's a long acronym. I'm not going to go into that. Conducted by Mia Kivipelto in Europe. They studied 2,600 odd people with estimation of low or high risk by the CADE score, but they put them through an intensive multiple factor treatment. They had nutritional assessment and sessions, exercise, muscle strength training and other exercise, cognitive training for 2 years. It was fairly intensive. And they did show that the intervention group had benefits in cognition. The difficulty with this is it's not immediately and easily translatable to the real world, because not everyone will have the ability to have that much of intervention. But it does show us proof of concept that we can do something about the trajectory of brain aging. There are other useful and emerging indicators of future risk that we're investigating. Taya Collier and colleagues, using data from the famous ESPRIT study, which is a Monash-led study, showed that the combination of walking speed and cognitive scores was useful in predicting future dementia in people who are about 70 years of age. So the slower you walk, potentially the higher risk prediction in the future. It's not a given. It's not just because you walk slow, but it's a marker. They've also shown that combining walking speed with a muscle strength measurement, grip strength, is also useful in predicting dementia. We're now progressing to work on newer kinds of cognitive tests. If you remember, I told you about the detection threshold. We're now able to use newer tests, such as digital tests. For example, this is a clock drawing task, which we might ask people to do. This is used with a digital pen, so it records the way they use the pen rather than just what the clock looks like. And that might give us a lot more information in the future. The future of dementia risk prediction and prevention really lies in combining all these kinds of clinical measurements, potentially combining them judiciously with different types of brain imaging, and maybe looking at blood tests and markers of brain injury. And a researcher in Monash in the School of Public Health, Joanne Ryan, has received a huge amount of funding recently to really look at this in the ESPRIT study. So this kind of work is probably going to change the field in the next 5 or 10 years. Finally, what can we do for people who have then expressed symptoms of dementia and come to our care? And this is by far the largest group of people that we deal with on a daily basis. Early detection of signs and symptoms and having a diagnosis is important. The question is, when do you seek help and why? Usually people are encouraged to seek help, either through a medical practitioner or specialists, if they have symptoms or cognitive symptoms such as memory problems that are persistent, that they feel are changing, and or it begins to affect your ability to function in your daily life compared with how you were before. There are other conditions that can cause these symptoms, and it's good to get checked out because these symptoms, these conditions can actually be treated quite well. So you might be pleasantly surprised that you've got something that you're worried about, but you can get treated, and it's not necessarily a dementia. It also stops the worry of not knowing and allows you to communicate with your friends, your family, so they can adapt to what you're going through as well. A diagnosis certainly can assist with consideration of specific treatments, linkages with services and support systems, such as those provided by Dementia Australia. Importantly, support for the carers who work really hard to help their loved ones, and potentially to access trials of new treatments that might come on board, because the earlier you are detected with symptoms, the more eligible you are for such treatments. As far as treatments are concerned, there's been a really long road to finding a treatment that can change the course of disease in people with dementia. So can we actually change the course? Till recently, we had probably 2 medications or 3 medications that raised the level of a chemical called acetylcholine in the brain. They were discovered about 30 years ago. Till recently, we haven't had anything else. More recently, there was a drug that was approved in the US that could clear the amyloid protein from the brain. It is an immunological therapy, but there are still some studies that need to be done to work out what its true impact is. The question is, are we treating too late? And is that the reason why we haven't had a treatment come up easily in the last 30 years? Or is it because it addresses only one potential cause, one particular pathway? And I've shown you that there are multiple pathways to dementia through the lifespan. The next frontier, however, is establishing really good paradigms for dementia care after a diagnosis. And these are some kinds of work that are being done by people in our campuses, in Peninsula Health, Monash University, as well as across the Monash faculty. Michelle Calisay has been provided a recent major grant to look at how to enable people with dementia to access things which they are written off from, allied health and rehabilitation. Chris Moran is being supported through the National Centre for Healthy Aging to try and see how we can better systems of hospital care for people with dementia when they come in, improve the experience when they come into hospitals. Darshini Aiton from the School of Public Health is looking at residential care and how people living in residential care with dementia can better access diagnosis and treatments. There are a number of us working within the National Centre, but you might have looked at and watched TV programs in the last year or two come from Sydney looking at intergenerational activity in residential care and how that connects people with dementia with younger people, children, and provides them with purpose and purposeful social connection. That kind of work, I think, is going to take more prominence as we go ahead. And through the National Centre, Keith Hill and others are progressing to develop those concepts and abilities here for us. So really, what I've given you is an idea of what dementia is about, what brain aging means to me and others in research, how brain aging connects to this concept of dementia, and what can we do for finding people early, preventing or treating people with dementia. Thanks for listening.
You're going to stand over here, and I've got to pick up my roving mic. Sorry, I'll leave something behind. That's my dementia. That was absolutely fabulous, CCS public lecture. So, thank you very much for that. I'm sure there'll be many questions. We already have a couple online. Does anyone want to start in the room, or should we? Yeah.
Probably a factor that's going to have an overwhelming influence on children as they grow and age is the digital world. You know, the games, the phones, etc., etc. Is anyone starting to look at that?
That's a great. The question is the digital world for children and how they access games and are quite involved in them. Has anyone started to research the impact of that? Honest answer is I don't know, but it's an exciting new field. So you'll find a generation of children over the last 5 years, 10 years at least, who've got a different set of skills and maybe certain different kinds of cognitive abilities which are better developed than previous generations. Does that have an impact on them in the future? We don't know yet.
And I just encourage people online to just type their questions into the chat, and we will get to them in turn. We might go to a question online next, and then we'll alternate with the room. So keep thinking of your questions. So from is the graph comparing death from with or without dementia, is the age of death the same?
Yeah, the people who were entered into that study were about 90 years when they passed away. So really the two groups were relatively well matched for age, if that's the question. So given that, I think the findings of the mixture of pathologies that help you express dementia and those pathologies that help prevent the expression of dementia quite strong. And that's been shown in multiple other studies.
Great. Now, sorry, apologies. I'm really proving my dementia. My mic was not on. So if anyone online did not hear, I said if you type your questions into the chat, we'll get to them in turn. Is any questions in the room? We'll go back to the questions online then. From does grip strength indicator reduce if the patient has hand arthritis?
Oh, without a doubt. I think when you measure something like grip strength, you'll have to take into consideration. If I were a clinician and I was thinking I'm going to measure grip strength and walking speed, I'd be looking for other causes of people walking slowly or people having lower grip strength. Arthritis is a common cause of that. People who walk slowly, arthritis is a common cause of that. So we just don't assume that because people walk slowly or have poor grip strength, they are at risk of dementia. It is one little piece of the puzzle that goes into a number of factors that we put in to get a sense. And our prediction abilities of those who might be at risk of dementia are at best moderate. They're not perfect at this point in time.
Great. I'm still looking around. Don't be shy in the room. Yes. Just repeat the question for...
Yep. So the question is, what is the link between traumatic brain injury and the risk of developing dementia? I think Terry and his group have done a huge amount of work in this field. If you looked at the picture that I showed about the lifespan and the factors that are important, one of the factors that are important young adult time is trauma, and head trauma is an important factor there. And there's a clear link between repeated head trauma in sporting injuries, for example, to the development of what we understand as chronic traumatic encephalopathy, and the kind of pathologies that you see in a person with that condition are not that dissimilar from some of the pathologies we see in people with dementia, such as the tau protein. So really there is a strong link between repeated and significant trauma to the head and a future risk of developing dementia.
Great. Going back online, what's the impact of alcohol abuse on dementia risk and type?
That's a vexed question. The extreme view would say to you that alcohol is a toxin no matter what. But we know that heavy consumption of alcohol is really bad. So the kind of figure that's put across in studies is somewhere in the region of 20 odd units in a week. But I think the lower amount of alcohol that one drinks through a lifetime, I suspect that it's protective in some fashion. There are several studies which go one way or the other in terms of working out exactly the amount of alcohol that you must drink for protective benefits or must drink to avoid harm. Personally, I think it's trying to avoid that as much as possible. Simplest answer.
Maybe not the funnest answer, but yes.
Way more exceeded my expectations. In the US, I read about people doing some studies into social connections and really missing the face-to-face communication, both online as well as in person. And they showed some remarkable results as a result of further grants to continue these studies. Are you aware of any such research in Australia? Any other research happening in Australia? Social connection, conversation?
So the groups in Sydney that have been recently funded to do a trial of intergenerational connections, that's the biggest piece of work that's beginning at the moment. And that's a national study that they're conducting. That is to try and promote face-to-face intergenerational connection to improve outcomes, not just for dementia, but for people in aged care overall. But dementia is probably going to be an important part of what they have. And so the outcomes from a cognitive point of view would be looked at, but I suspect it's a holistic outcome of their quality of life that's going to be important for them. Locally, with the National Centre of Healthy Aging here, where Keith is involved, we're developing some new facilities that will allow that to happen in the community here in the Mornington Peninsula. And that'll come on board probably in the next year or two. And when that comes on board, we'll be able to test a lot of things here.
We might go online, so hold that question. So you mentioned cognitive activity as a treatment to delay dementia in older age. What about education, occupation, i.e. cognitive stimulation earlier in life? How does that protect you or not?
So I pointed out the fact of reserve, resistance, resilience. The reserve is how much reserve your brain might have or your cognitive abilities might have. Resistance is some innate body's ability to resist harmful pathologies from occurring in your brain. Resilience is even if you do have those pathologies, how does your body adapt and overcome those? All these outcomes are being studied as we speak, but there's a huge body of work connecting childhood attainment in education as an important marker of all these constructs. So really as much stimulation, whether it's physical, mental, social, right through your life, particularly in the younger formative age, where you can actually pick up higher and potentially come slower down the track of brain aging would be preferable.
Great.
I was just wondering if Monash is going to have any interaction with the Herd Intergenerational Centre being built this morning.
We already have. So we reached out last year to the Herd Centre. This is the question for people online is, have we reached out to a centre that's being developed in the Mornington Peninsula for intergenerational connection between kindergarten children and people living in residential aged care. Uniting Age Well, I think, is the provider, and on that campus is a new kind of centre which is being developed for developing a curriculum for kids to engage as well with older people in the facility itself. So we've connected with them through the National Centre for Healthy Aging, and we're in the process of working out what paradigms might work and could be tested.
Fantastic. So back online, is there a reason Japan has such a high rate of dementia due to their life expectancy, the way you sample, the population, or other reasons that seem to be up the top of your graph?
So the thing about studying prevalence of dementia is the methods used. So at the heart of it is, I'm not sure if the methods used in every country are very similar. So I suspect that would have an impact on some of the differences in prevalence. In terms of innate risk to dementia, I'm not sure if we understand anything specific, except to know that in Asia and in Southeast Asia, there is a higher predilection to vascular health problems in the brain. So risk factors such as salt intake, activity, urbanization, all that could lead to higher levels of stroke and vascular disease. That could be one contributor. That's as best as I can provide as an answer.
Yeah. Good question.
Absolutely, and one of the, if you looked at that curve,
Repeat the question, sorry.
the question, pardon me, is what is the connection between sleep and quality of sleep to the risk of developing dementia? There's a whole body of work that's coming out that suggests that sleep is somehow related to how your brain refreshes itself, but also maybe the proteins that develop in the brain are somehow regulated by the factors that are linked to how we sleep, the hormonal factors maybe. There is a body of work that's being done through the ESPRI study trying to work out if sleep quality affects the risk of dementia, but it is a factor that is promoted as an important thing to address to try and reduce our future risk, amongst a whole morass of other things as well.
Of course, sleep quality deteriorates as you get older. So,
as we get older, in the later stages of life, there are a number of things which are different. And so our muscle bulk reduces, our sleep quality reduces, our diets change and the appetites change, our body weight changes. So there's a bit of an inverse relationship that happens between those factors and the risk of dementia at that time. But when we're talking about prevention from now to a future stage, these factors are quite important.
great. So back online again, once the presence of tau has been established, is there any treatment to minimise it?
I'm going to put that question back onto Terry. I think Terry's the best person to answer that. I think people are feverishly developing methods to try and reduce the impact of tau. Terry, if you want to tell people about the study that you're conducting in people with frontotemporal dementia.
So
that would be useful.
Yeah, even though it's not my show, this is an area close to my heart. We have been, our group, along with Lucy Vavich and Dennis Velakoulis over at Royal Melbourne and Chris Hovens at the University of Melbourne, have for a long time been looking at a substance called sodium selenate, which is an oxidized form of selenium, and has a very powerful effect to dephosphorylate, which is the sort of the nasty toxic form of tau, and reduce tau burden in the brain. And our particular interest has been initially around traumatic brain injury, epilepsy, but now we're doing studies in a couple of dementing disorders or neurodegenerative disorders that we know have, at least in some people, a tau-based pathology, including frontotemporal dementia. So if anyone has any relatives with frontotemporal dementia, and also another neurodegenerative disease called progressive supranuclear palsy, or a PSP. So yes, look, possibly, but these studies are also are in trial at the moment. There has been some commercial studies of antibodies to reduce the level of tau in the brain. So far, not with a lot of success, one must say, but it is certainly an area of active research, both in the school and beyond. Any other questions in the room for the moment, or we'll go back online? Is there any understanding as to why it is more a leading cause of death and disease burden in women? So why women so affected?
Good question. There are differences in prevalence of dementia between men and women. Women tend to have more prevalence of dementia seems to be more in women than in men. Part of that is because women tend to live longer than men. So that's one of the reasons why. There's also an element of what happens in midlife that might contribute to a change in trajectory of brain aging. So during menopause and hormonal change, there might be a difference in the way women's brains work or are protected. Estrogen is a very strong protector of what the brain looks like. So that would be another component in the puzzle. Why is it a cause of more burden of disease in women? I suspect it's because they live longer, they accrue more disease in combination with dementia, and that is part of the reason why they have more disability, I suspect.
Because many of the risk factors you mentioned are actually more common in men.
Correct.
So, like obesity and
the paradox,
high blood pressure.
Of dementia between men and women is the next. I think you'd find that Joanne Ryan's study on biomarkers that she's been funded for is to look at that difference between men and women as to why people behave differently.
Yes, question.
Thanks, Srikanth. That was great. Just on the same topic, I know Steph started looking at this, but in that group. What about the role of gender rather than sex, and particularly from the older women and educational opportunities and employment and that sorts of factors?
So the question is it not just biological sex? Is it also gender, which influences behavior? And how does that behavior vary within women and between men and women through their lives to explain this? Generationally, I think the previous generations might have had a different perspective of what a healthy lifestyle might have meant. Now, as we go forward, women nowadays might have a completely different outlook to what a healthy lifestyle might be. So in the future, we might see that cohort effect has an impact. But without a doubt, it's not just whether we're men and women by chromosomal status, but it's about the behaviors that are built into who we are.
Great. Back online. Does dementia increase the risk of falls, and why? So they're associated, but does it actually have a causal role there?
I think it does have a causal role. We've clearly shown that there is a strong link between the establishment of cognitive decline and the future risk of falling. And clinically, the reason is fairly straightforward, I think. To walk, to have good balance, to be able to judge your surroundings around you and the risks with the surroundings, you're going to need your brain to be working in top gear. And when that's not working in top gear, you're going to have the risk of stumbling, falling, and injuring yourself. So I think the answer for that is a yes, and the answer in terms of the reason why is fairly straightforward.
The questions online. So on the room. So another question online from: Is episodes of TIAs? Does episodes of TIA indicate some diseases exist in the brain which may lead to dementia later on?
So TIA is what's referred to as transient ischemic attacks. These are episodes which people suffer very briefly. They have loss of function of the arm or leg or speech for a few minutes, and then they come back to normal. In a usual sense, these are predictors of a stroke that might happen. So they're linked to the presence of stroke coming on later. But some people with these conditions can have other kinds of changes in their brain which mimic those usual TIAs. So some of the scans that I showed you, people have little hemorrhages, microhemorrhages in their brain. They might also have hemorrhages in the convexity of their brain or the outer surface of their brain, which is due to a condition called amyloid angiopathy. Very rarely, but not infrequently, we find that such people come with so-called TIAs. They also have amyloid deposition in other parts of their brain and potentially are at risk of dementia. So that is one mechanism by which these so-called frequent TIAs might be a sign that there's something that you've got to look for on brain scans.
Okay, well, we might just take two more quick questions online, unless there's any burning ones in the room. So is there any evidence on the balance between intellectual activity and physical activity, and may a combination of both be more effective in slowing dementia?
I wish I knew the answer to that question. Honestly, I don't know the answer whether the combination of both amplifies the effect of each. It's hard to do such trials. You can do trials of physical activity and exercise. It is not easy to combine that with intellectual activity as well. The group there's a group in the University of New South Wales, Professor Sachdev and his group. They're doing quite a bit of this work, and I suspect that might come out more.
Okay, so our final question. Given the high prevalence of mixed dementia diagnoses, are these dementia subtypes considered distinct conditions, or is there evidence that there will be these are just different expressions of a shared underlying pathology?
My bias is the latter. It's a clear bias, but I think it comes out of looking at these kinds of data which suggest that, you don't see just one thing in someone's brain if they've died with dementia and you've had a chance to look at their brain. Considering just a unitary cause is putting your head in the sand, except for conditions such as frontotemporal dementia, which you're talking about, which have a much more clearly delineated set of causes for that particular condition. But that's my bias.
On that note, we might finish what really has been a fabulous CCS public lecture. Thank you all for your attendance, both in the room and online, and for your fabulous questions. Really wonderful discussion. An area that I think we can all relate to sooner rather than later, or later rather than sooner, one hopes. So thank you again to Professor Srikanth for a wonderful lecture, and everyone organised with organising this.
Thank you.